Good morning, good noon, good afternoon. Hello, everybody. Happy Friday. You get another RLR with the capital R on his way. I am thrilled today because I got a chance to hang out behind the scenes and learn of the awesomeness of the CP Solvers Academy. We have Moon on scribing, and since she hasn't done it more than 5 or 6 times, less than that, she's got a whole team of CP Solvers Academy members supporting her. We're very, very excited for that. Uh, the legendary and now highly, highly established Jimena is doing teaching points today. And um, we're very, very lucky to have a second time piece presenter. Dr. Avi, do you want to unmute and tell us a little bit about yourself?
Hi, absolutely. I'm Avi. I'm a transitional year two neurology resident at Emory. Very soon, officially wanting to become a neurologist. But something that I'm passionate about is connecting medicine to neurology. I feel that's a niche that's getting less and less emphasis over the time since now we feel we have neuro folks to consult us on things. But I think this has been a beautiful platform for me to still keep that love alive. The other thing that I did also talk about last time was something that I do is called medical poetry, um, which is connecting medicine and topics that I feel have affected so many of us. But as doctors, we sometimes go in too much depth that we lose touch with our patients or sometimes with our students. So I think that is something that I do in my free time to keep my medical and artistic sides alive.
Gosh, there's so many sides to you that you've shared with us. Thank you so much. I'm really curious, where does the medical poetry, if you had to trace the origins of the development of that interest of yours, where does that come from?
So actually it was a couple things. One, like all of us, most of us having grandparents who have diabetes and who've had doctors tell them, oh, you know what, you don't control your diet at night. That's why your blood glucose is terrible, or you can't have surgery. And they've heard this a million times. And as doctors, we just repeat the same things, but we forget like how it impacts a patient, or there could be other things going on psychologically. So that was my first poem that I wrote called Diabetes, a Lipophilic Legacy. Uh, and the second one was actually a poem called Atypical Minds in a Stereotypical World, which was on autism. And I actually ended up sending that in my personal statement for my interviews. And I guess it worked. I ended up at Emory.
Really incredible. Do you publish your work, or is it accessible for other folks to read, or where does it live?
So most of it is on my YouTube channel. It's
Oh,
called
wow.
Medically Mediocre. Uh,
My gosh.
And like I have a couple like books published with like other authors in different languages. But I'm still trying to like compile a few more to like have a dedicated medical poetry.
Oh my gosh. I'm just opening up your YouTube channel. Oh, I recognize this guy. That's so cool. Wow, I feel like I'm in the presence of celebrity. That's so, so cool. I highly encourage you all to check it out. This looks really cool. I can't wait to check it out afterwards. Yeah, I'd say you're far from mediocre, my friend, but that sounds incredible. And I'm curious in parallel to that, how did your interest in bridge neurology and medicine, where does that originate?
I'm sorry, I lost you there.
I'm sorry. I was just curious in parallel, where your interest to bridge medicine and neurology, where did that come from?
So essentially, I think when I realized I was in love with neurology was in my second or third year of med school when I was just explaining how circle of Willis is actually a three-dimensional structure instead of what we usually see in the books. And I had like my colleagues like, oh, no one explained it to us like that. So it's not that tough. Like, so there's this sense of neurophobia that exists all around. And again, I think that that stems from the fact that when we're starting to be taught neurology, we're just made to feel that it's one of those disciplines of exceptions, like why does your facial nerve pass through the parotid, but it doesn't supply the parotid? And almost everything has an answer. We've just not thought about it long enough. And I think medicine as it is the mother of most other specialities. That's how I feel it. So I think it's important to like empower medicine folks as much, so that that connection, that interdisciplinary approach becomes much better. So I'm actually working on a project called Neuromedicina these days, which is like pearls of neurology relevant to medicine residents. So it's still in works, but I would love to share it with you guys someday.
Easy. Well, I'm curious, have you presented on Neuro VMR or I would love to connect you with Aaron if you haven't been connected yet.
Actually, this like this one and the previous ones were like medicine VMRs, and I think that I'm also trying to like keep myself attached to medicine as
I
much
see.
before
Understood.
before I
Understood.
uh
Understood.
choose
Love it. Yeah,
neurology.
you want to I understand. You want to develop deep roots in a place before committing to neurology. Hey, I love that. I feel like you and I have very similar interests. I think I come at it from the medicine angle with a
Mhm.
very strong passion for neurology. I know Prof Rez, who just joined, feels very, very similarly. Prof Rez, we're getting to know Avi, who is essentially trying to live in the world of medicine and neurology, leaning more and beginning more on the neurology side. But I was just sharing our love for neuro and the benefit that we have to learn from Aaron. Good morning, Prof Rez.
Good morning, everyone. How's it going? Hi, Avi. Hi,
Good
Ravi.
for you.
I couldn't be happier, Prof. As I get to hang out with you guys, and I'm getting to have my delicious breakfast, and I'm excited for Avi's case. I have a sneaky suspicion that if it's based on your interests, we'll know where to go, but we'll see what you have in store.
I don't know. I don't want to reveal.
All right. Well, I think Parisa is sharing her screen. Whenever you're ready, Parisa, let's rock and roll.
Perfect. I'll start with talking a little about what this case is about. The chief complaint is facial droop and left arm weakness. Um, so the first aliquot is part of the HPI itself. So this was an 83-year-old male with past medical history significant for hypertension, hypothyroidism, status post radioablation, and congestive heart failure with minimally reduced EF, who presented with 5 days of left facial droop and left-sided weakness. At baseline, he lives at home, completes most of his ADLs on his own, and was almost in his normal state of health when he fell backwards in his kitchen about 5 days ago, while turning around and hitting his head on the pantry door. He did not lose any consciousness at that time and denied any headaches, no dizziness or confusion. But since the fall, he's had worsening left-sided weakness, some facial droop, and some difficulty swallowing. He says that he had been sleeping well. However, he does admit that he might have lost some appetite in the last few weeks.
Very intriguing. Prof. Rez, how do you feel about jumping in?
I love to hear some math.
All right, you got it. I think the story is very, very intriguing, and I think that whenever a patient sets us up by then recounting their story to associate two things, we immediately, I think, make a judgment very quickly about whether there's reasonable plausibility for those two connections. So if just yesterday I had a patient who came and said, "Hey, my left elbow, my left elbow really hurts." If they said my left elbow, immediately, like you can't connect those two things. But if they say my left elbow hurts and I bumped it in the door 2 hours ago, you would immediately make the judgment that those two things are connected. And I think if you latch onto that instinct here and you say the patient has a left-sided, a unilateral neurological syndrome in the context of a recent fall, I think you can easily see how that could happen. So, for example, if the patient has a contralateral subdural hematoma with
Mhm.
compression, you would find that to be plausible. But then you listen to the rest of the history that's described, and you're inclined to disconnect the fall from the neurological event, namely to disconnect the initial instinct, which is to say that the neurological event is a consequence of the fall. And I think all that's happened in my mind now is to view the fall and the trauma with a great deal of scrutiny and wonder whether it's related at all to what happened, whether it's a consequence of what's been going on, namely his more subacute symptoms, um, or whether it's purely coincidental. So what's happening in my mind now is I'm analyzing the data um, without strong attachment to the trauma. And I think that's where there's a little bit of a conversation that Prof. Rez and I can have. But I think that's my first instinct is to like, hold on, no, don't connect these two things, and let's study the syndrome. So I'll pass the mic to you to see where you're at with like studying the syndrome itself, Prof. Rez.
Yeah, I think that's really clever, especially when you had the right arm with in terms of the left arm versus the left arm. Uh, but here's the deal. Like, I'm a little astonished that the patient didn't come to clinical attention earlier. That isn't another thread that we have to seek because, like, if you're having left-sided facial droop and left-sided weakness, you imagine you would go seek care. And so I'm really curious as to whether it's the lack of access to care, the lack of insurance, the lack of health literacy. There could be so many things, but I think it's another component that's important to address. Here, we just apply the neurologic equation, which is the neuro DDX is equal to localization times the tempo. And here, the localization, everything is sort of left-sided weakness, which correlates with the contralateral right side of the brain. And because you have facial droop, we know we're dealing with a lesion at the level of the brainstem or above. And most likely, you can either be dealing with like just a right-sided cortical lesion, or you can have multiple lesions, and these lesions, they can be from stroke to demyelinating processes to tumor. They can take on many forms. But I think right now, Robbie, because of the unilateral nature of the symptoms, I'm quite confident we're going to find pathology in the right hemisphere. And the difficulty swallowing too, that, now you're talking about cranial nerves because the facial nerve, cranial nerve 7, is responsible for lifting of the facial muscle. And you have to be able to distinguish that from like a peripheral 7 where you just can't raise anything. You get complete, it's almost like you got Botox all over the place. But here he has difficulty swallowing. So now you're in that cranial nerve 9, 10, 11-ish categories. So I think, and then the tempo, usually with stroke, the patient would come suddenly. So it'd be very odd that they don't present suddenly. So I'm thinking this is more of like an acute onset as opposed to a abrupt onset, like stroke, seizure, bleed, metabolic disturbance. And there with the acute onset, here you're more concerned for an inflammatory process that may exist, like an MS, which you remember the case. I mean, this guy is too old for that, and he's a guy, but we had a case very similar to this in Geneva, but it was a middle-aged man who presented with left-sided symptoms. That's all I have to add. And then I'll just say the connecting the dots, like, could that lesion on that right side of the brain make him vulnerable to, I know he didn't lose consciousness, but make him vulnerable to a seizure and then a fall? Or is it just the weakness in itself that led to a fall? And now we have to deal with the ramifications of that fall, which might be a subdural. So all that is to say, I think he needs an MRI of the brain with gadolinium to just look to see if we're going to find any demyelinating or any pathology in that right hemisphere.
Absolutely love the thoughts. And I think you definitely covered more base than what we might have thought initially. Because like you guys said, initially our brain runs to connect the dots. Because like, oh, we are so familiar with some focal deficits, so it should be, and it is the left-sided weakness might be explained by something on the right side, and then this guy has a ground level fall. So a few things that happened protocolized wise, because he had a fall, he did hit his head. We did want to get a CT right away. So I'll talk about that in my next aliquot, but with just some collateral information to run the case. At home, he just takes some Cozar and amlodipine for his hypertension. Also takes his Synthroid 25 micrograms because he had post-ablative hypothyroidism. We also asked him about his baseline a little. He's a police officer. He's a retired police officer, actually. So when I saw him, I was like, sure, he's an aged guy. Maybe this is his baseline. He's talking slow. He's also blind in both his eyes. But that is chronic. And I was like, there's no way this guy does all his ADLs at home. And the moment I talked to the family, they're like, oh, what are you saying? He does almost everything at his home because his personality is also super strong. Like he does not want to be dependent on stuff. He hates taking all his medicines, but he still takes them. So I talked to him, so like asking him why and when do you take your medications? So he says like they think that I take my medications, but I probably do end up missing a few of those every now and then. Um, so I think that those things were important in my head to start thinking in the direction of what could be going on. But we did get some basic labs on him as my second aliquot. Almost everything looks good except creatine was 1.6, GFR was 42, cholesterol was 272, HDL was 66. Importantly, his TSH was 79.22. Uh, and his free thyroxine was 0.25, which I think were pertinent. Also, I would just put in the same aliquot. We did get a CT right away because that was done alongside, because he had a ground level fall, which did not show any concerns for any bleeds, any large territory infarcts. The only thing that it probably did show was severe microvascular ischemic changes with multiple chronic lacunar infarcts, which were explained by his hypertension and risk factors that he's had, but no large vessel occlusion. Also got a CTA apparently while he was on the table itself. Some cervical spondylosis, but nothing in the brain itself that we found on the CT at least. Um, and just to put into context, on my physical exam, like was mentioned, there was some drift on the left side, just 4 on 5 strength in the left upper extremity, left lower extremity. The droop on the left side was mild, did not involve the upper part, did not involve the forehead at all. But overall, he was oriented to place initially at presentation, but not AO times 3. He was definitely slow. And I mean, overall, he was generally slow to me. So I was feeling that something beyond just focal is going on. At the same time, we did have those focal deficits as explained, but nothing else on my physical exam besides that.
Well, since I talked so much for the last aliquot, Robbie, dissect this and attack it, my man.
Whereas I'm very intrigued um, by this scenario. I think it's almost like the exam is clashing with the history. And the reason they're clashing is if you really just start by saying what the chief concern was, the chief concern is facial droop and left arm weakness. But I think that the thread that Prof. Rez picked up on, which is why did this person not seek care earlier, might have already been now catapulted to the most important problem. Because one, we're hearing that his perception of how he approaches taking care of himself might be different than family members. And that's an interesting thread to think on. But most importantly, I think you're picking up the sense that he might have an altered sensorium. And I think it's very, very dramatic to have half your body not working. And when the patient is not struck by how dramatic it is already cause for concern to wonder what's going on with their global cerebral dysfunction. And now that you've noticed that he's not quite participating as well and has a diffuse encephalopathy that may be subtle, I think it becomes really, really important to ask yourself what the nature of the problem you're solving is. And I also think, given how mild and subjective the left facial droop is and the left weakness, I think we now find ourselves in a space not really knowing exactly what the nature of the issue we're trying to get to the bottom of. Is this that this patient who's 83 has mild encephalopathy, or is it that he has mild focal weakness, or is it both? And so I think doing what you did, Avi, is so key, is to try to establish like who is he at baseline and how functional is he at baseline. And I think how different he is from what he was 5 days ago is now hard to know. And so I think what I would try to do in real life is to recognize, well, okay, there's no emergency here. Patient is relatively stable. And I just need to know what the delta of neurosymptoms has been over what period of time. And I think that investigation will help you decide how thoroughly you need to investigate his case. And I think that one insight into the delta of symptoms over the delta of time is the TSH. And the fact that his TSH is so high, meaning that he hasn't been taking his thyroid medications for quite some time, might transition this case into a more subacute encephalopathy with focal features rather than the 5-day time course that we have. So I'd be making some phone calls, trying to talk to people to be like, who is he like, and how much off his baseline he is. And I think I'm starting to suspect that this is a more subacute protracted syndrome. And I'm even wondering whether focality is worth investing in here or whether it's a distractor. Curious where you're at, Prof. Red.
I love that. Exactly where you are. And maybe one question I can ask Avi. Avi, his voice, how was it? Was it hoarse or was it normal?
So it was smooth, not hoarse, but definitely slow. He was delayed to respond. So I would even call it more of an issue with his response time than his phonetic muscles.
Got it. And Avi, we don't know why he has a history of hypothyroidism, like the etiology to that at this juncture. We don't know why.
So actually he did have a radioablative hypothyroidism. So he has
Oh,
been, and it runs in the family. So one of his daughters also had hyperthyroidism, familial hyperthyroidism, and she had a surgery performed, whereas he did have radioiodine ablation performed.
I got it. That's so helpful because we know hypothyroidism by definition, like everything is slow. Like your
Mhm.
movements, your mood, the quality of your voice, everything slows down. And if you ask the question, like the end result of that is mixed edema coma, where you become hypothermic, you're no longer aware, you're sort of unconscious, you can get some pericardial effusions, hypoglycemia, etc. So I think, Robbie, the question becomes like, we have one objective data. We're where we were last time. You remember where we had that unbelievable RLR case? The patient had the diabetes, but then had the thrombosis, and then and we had to keep asking what had a seizure, like all of that. It's like that Celine Dion song. It's all coming back to me now. But let me ask you, Robbie. So, like, would you feel comfortable like saying, hey, all this is hypothyroidism. And what I need to do now is replace the thyroid hormone? Or are you like, wait a minute, there's something off the unilateral nature of his presentation? Like, do I need to also get an MRI of the brain? Do I have to get an EEG? Like, where are you in terms of those thoughts?
That's such a great question, Prof. Red. And I think at the root of it is the question of what is the significance of a TSH of 79? And I'll tell you, I've seen many, 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 many patients with TSH is much higher than this who have no symptoms whatsoever. And so, and so I think that unfortunately the degree of TSH abnormality is a mild correlate with the probability of disease. And so I think it's now all about trying to say, is this clinical syndrome here compatible with mixed edema coma? And there's certainly many aspects that are, especially the slowness. But I think without bradycardia, without edema, without other things, you would certainly probably list it as a contributor, especially if the free T3 and free T4 are low. But I think there's a lot of red flags to understand if there's anything else going on. Because I would say that mental status abnormalities are way out of proportion to any other abnormality we see associated with mixed edema coma, including the sodium, the temperature, the heart rate. And so I would be reluctant to ascribe the syndrome exclusively to that. But I think it's hard not to see how if somebody has something else going on, a TSH that high will certainly not make it better. But I think a more classic description of mixed edema coma will involve more swelling, more edema, more electrolyte abnormalities, more heart rate abnormalities, and more temperature abnormalities. It could just be that this is an unusual presentation of mixed edema coma, but I think that there's too much diagnostic, there's too much unexplained to not investigate it further, especially when you can easily find a sequence of events where a patient has another problem, stops taking their medications, and then this thyroid issue can camouflage the original problem. So that's where I would be at. What about you?
I agree completely. And I think the next series of tests, one should be an MRI, and then you got to start thinking, do I need to get an LP to better understand, what's going on in the CSF space? And I know there's that entity of Hashimoto's encephalopathy, but I don't think that applies here because this patient's hypothyroidism wasn't from Hashimoto's or autoimmune thyroiditis. Rather, it was from radio ablation. So I think Avi, where we would go next is like an MRI with gadolinium, and then depending on what that shows, maybe an LP. And it's important to get the MRI before the LP. One, it's like easier for in a resource that in a setting that has the resources to do the MRI. But the other reason is that the LP can alter what you see on the MRI and cause leptomeningeal enhancement itself. So like if you have to choose which one to do first, uh, in a case where it's not like acute meningitis, it's MRI before LP.
Those are all great thoughts. And I love like how there's so many strings in the mix at the same time. Because essentially that is how we were concerned. And to put my next aliquot, it was something that was done by the primary medicine team that I was a part of at that time. That one day when we got these TSS results and trying to correlate the loss of appetite, his slowness, I think it just struck everyone. They started asking the right questions. Oh, have you been taking the thyroid medications? And he's like, actually, probably not for so many days. And I just don't like taking it. One thing that also hit me, he was taking his thyroid medications, if at all, with his food. So even if he's taking it, probably the absorption is getting affected. So it's definitely like making sense of having his TSH that high. But I agree, the electrolytes looked fine. If at all, he was low normal heart rate, did not give a complete picture of a mixed edema coma, but I think the primary team still felt like this definitely is on the spectrum somewhere. So they right away, with over caution of it being mixed edema coma, they did give like 200 micrograms of IV levothyroxine. Uh, and then thought like and consulted endocrinology right away, which did not see the patient until later the next day. Uh, but to just add to the aliquot, the next time that I see this patient, his voice is so much better. He's responsive much more better. Um, he still has some weakness on the left side, similar 4 out of 5, upper and lower. His droop is somewhat better, but if I activate it, his smile, he still seems a little asymmetric. But he's responding so much better that I remember myself thinking, "Oh my God, like we he seems like a different person." And now it makes sense to me that this guy might have been able to do his ADLs at home. That was my thought process in that moment. um the other thing that also happened during that time was obviously a few other labs that were being done. We got a transthoracic echo at that same time. I think stroke labs as part of the initial stroke lab workup that revealed some uh, the TTE revealed no thrombus, no intra-atrial shunt. Left atrial size was normal, but there was some pericardial effusion, trace pericardial effusion, like you very rightfully thought about, Reza. And then there was also some global hypokinesis of the heart. So I remember talking to endocrinology and trying to correlate, like, can I know like hypothyroidism can cause like some pericardial effusions. Can it also explain the global hypokinesia just from the thought process that everything's getting slowed down? So they weren't super sure about that. They didn't feel that that would be a case, but they did reach us back with the fact that they wouldn't have probably treated it as mixed edema coma. However, they did put like they took into account that we've given this amount of dose, so they left one day of synthroid vacation for the patient, started him on 125 micrograms, that he definitely needed some regular dosing of synthroid. However, as very rightfully pointed by Reza and Rabi, we ended up getting an MRI because we still were concerned, like there was some focality to it as per neuroconsults as well. And the MRI did show us an acute ischemic infarction in the right corona radiata, which pretty much essentially correlated with his deficits. Some scattered foci of hypertensive microhemorrhages, but it did reveal a new infarct there. So I think that was a beautiful realization that there were two simultaneous pathologies going on, explaining two very different kinds of symptoms, and I can talk about it later. But over to you guys.
I think that this case is just so illustrative of the need to really do what you did so well, Avi, which is to go back and really try to understand the nature of the problem that you were dealing with. And I think the nature of the problem that you were dealing with was one in which there was obvious focality, but I think also the pickup that the patient also had a global cerebral dysfunction probably was easily overlooked initially. You see the facial droop, you see the arm weakness, and I think all too often we try to find a unifying hypothesis that explains both things at the same time. But I think it's a really elegant way of seeing how patients who have chronic conditions, those chronic conditions really require that the patient compensate for them in some way, shape, or form, often by taking medications, but sometimes doing things. And a new, completely independent insult, such as getting a stroke, may make it so much harder for you to subsequently compensate. And so I think that this is why for almost any chronic condition that decompensates, be it hypothyroidism that gets worse, or COPD that gets worse, or heart failure that gets worse, we have a list of triggers. And what triggers somebody to stop taking their medications, what triggers somebody to go into mixed edema coma, really has to be analyzed in everyone who comes in. The analysis is so much easier when there's a parallel clinical syndrome that allows you to follow the thread of what that trigger is. So, for example, if somebody comes in and comes in with decompensated heart failure, but they also have crushing substernal chest pain, you now can easily see that you should run the triggers of congestive heart failure in everybody. But the presence of a parallel clinical syndrome, namely crushing substernal chest pain, allows you to very quickly conclude that this person had an acute MI causing their decompensated heart failure. And so I think in this case, you can see that the patient has slowness, a slow voice, is lethargic, has what was the finding? I forgot the other finding that you picked up. Oh yeah, just his slowness to respond. You're like, oh, okay. Has hypothyroid. He's slow. I'm worried about something on the spectrum of mixed edema coma. Why? And you have to answer that question, why, in everybody. But it's so much easier to be like, well, in parallel to this, I have a focal unilateral neurological syndrome that is lacking cortical signs. That's a lacunar stroke until proven otherwise, as Prof. Rez said. And so I think the constellation of these two things really, really aligns very well. You could have another parallel conversation now about, well, why is he having a stroke? And I think that's an interesting thing to talk about. But I'm really curious what you're thinking, Prof. Rez, and how you're putting it together.
Yeah, first, I just want to congratulate Avi for just doing such a superb job in caring for this patient, and also bringing a case that's truly bread and butter medicine. Like, this is what we see on a regular basis. So I appreciate you, Avi. Like, this is very practical for a lot of the listeners that are following along. And it's so interesting. Robbie, you had mentioned, like, if someone is acutely stressed for whatever reason, maybe they stop taking their medications. And so it's so easy to see how the TSH level could rise because someone has a stroke or has some kind of event that prevents them from taking it. But there's another way you can like flip the script. I don't know if this is true or not. It's something I was trying to Google right now. Is that could you have someone with prior stroke who now has hypothyroidism, and that state of hypothyroidism and the stress on the body is causing a recrudescence of that prior stroke? I'm not sure if that's true or not. Maybe Tiago can comment in the chat, but I'm just trying to look for ways to link A to B and then also B to A in that direction. But I thought it was a very good case. And yeah, and at the end of the day, when you do have unilateral symptoms, you have to rule out stroke, you have to rule out some kind of lesion in the contralateral hemisphere. So Avi, would love to hear from you as to like what your learning points were. How long did it take you guys to get to the diagnosis? And what general life advice do you have for our listeners?
Yeah, absolutely. I think this was one of the most rewarding cases that I worked on. So we do have 2 week blocks. This was a patient that came to me. I wrapped him up. I knew what everything's going on, what his management was going to be before I left the service. So I think that is one of the rare occasions that happens as residents. But I think you've got to hold on to such cases, know, own the patient, own everything that's going to be done to the patient beyond them leaving the hospital and you feeling comfortable, like he's been set up for things that need to be done for him. I mean, we talked about the core learnings that we learned here, but I cannot emphasize the amount of things that were still that I still learned much more than I could talk here with him. For instance, like the MRI did reveal a stroke, but that was not the end of the story. It revealed a 1.2 centimeter stroke that was kind of also concerning for an embolic looking stroke more so than anything else. That was the neuro read. Like they weren't feeling super comfortable saying that this might just be a small vessel disease. And then in that moment, they suggested us to get an intra loop recorder. We consulted cardio to get that done because he was already on DAP now because of stroke. We initially held the Plavix. He was still on aspirin. The ILR procedure got him to bleed so much from the site of chest incision. We literally had to use the very basic medicine of literally putting chest pressure to stop the bleeding for about 2 days. So just knowing that all the fancy things we have at the end of the day, also remembering what the physical maneuvers are to get things done in the right direction. Uh, so I think one thing that I learned and I wanted to share as a neurological side of things to medicine folks back at my institution as well was, why are we being so picky about wanting to find an embolic source if the echo did not reveal anything, no atrial fibrillation, because we might have missed it. And the reason we're being so picky about even inserting a loop recorder into someone to catch that AFib if there is because that changes management altogether, right? Because if it's AFib, then the risk of a recurrent stroke compared to one due to small vessel disease or even a large vessel disease is so much higher that you want to catch it and you want to put the patient on appropriate management. So I think that will still be taken care of by outpatient neurology and cardiology. But that was one learning point. The other learning point that I feel the family helped me so much with was because this was the family of a policeman. They wanted to know everything, what's being done to their patient, and he would want to know everything about it. So what are you inserting and stuff? And I forced myself to talk in ways that made sense to me, but made sense to them. So when I'm telling them about ILR, they want to know what exactly is going on, all the consenting procedure. And I'm up to speed because I cannot mess it up here. I need to tell them what's going on.
Avi, are you sure you said ILR and not RLR?
No, I think
No, I'm just joking. RLR is our company, our other company.
and yeah, so what happened was like they had this regular question, when and how is he gonna improve and what actually happened to him? So I think one conclusion that I reached, I tried to explain them, like the more generalizable things, the slowness which has improved was more likely explained by his hypothyroidism, which already is somewhat improving. And I remember having this conversation on the very second day. And I was like, the focality, like these things that are on one side or specific to one part, are more likely probably explained by the stroke. But essentially, I know like if it's some recrudescence or some other phenomenon, these things can overlap somewhat, and that's why we're never 100% sure. So I think I resorted to definitely explaining them in a way like we're doing things in both the directions. The things that end up improving are probably due to the hypothyroidism, and the things that end up not really improving right away are probably due to stroke. Uh, and we're hoping for the best, and in a way, just explaining it to them. So this might come across as a good news that the hypothyroidism did cause all those terrible looking deficits that scared you, but they are ultimately reversible. So we educated them on thyroid medications. And at the same time, we caught a very real risk of having a recurrent stroke. So also making sure that, because I'm sure that that person was someone who would not have started taking his medications unless something happened to him. So I think that incident was a great opportunity for me to get him to follow up with his services, make his family aware what needs to be done. Uh, and I think by explaining them exactly what was happening, I pushed myself to understand things not just in a very theoretical way, but in a very practical way. Like we had a couple times when we had to consult SLP, speech and swallow, changed his diet from NP to NPO because he could not have it. And I was like, maybe if it's due to stroke, the next day, forcing the SLPs to reevaluate the patient because we think he's getting better and he needs that reevaluation, and not just giving up because, oh, you just saw him yesterday and there might be no change in recommendations. And they literally changed the recommendations from NPO to please have him start eating food because he can eat today. So I think all of that in a span of 14 days was an amazing educative experience for me. Also feeling that we actually did some good to the best possible extent as we could as doctors. So yeah, that's about it.
Before Robbie jumps in, I just have to say my favorite part. First of all, that was amazing. Robbie will give you a lot of flowers and balloons, but I just want to say my favorite part was this guy needed to have a stroke to change his behavior and take his medications. I love that.
I was gonna say almost the exact opposite, Avi, which is that that I'm still processing what Prof. Rez emphasized. Yes, that's incredible. I think that I think forever and ever and ever, if you ever get stopped, have a traffic stop, or get yourself in any trouble whatsoever, just replay this YouTube video, and I think no police officer would ever arrest you or cause you any harm for the outstanding care you've delivered to their colleague. So I have a sneaky suspicion there are two motives for this presentation. You are forever free of any consequences. But yeah, this was such a great demonstration, and I think it's funny how these the intros that we do to get to know you really shed light on your personality and who you are. You told us that you thrive in understanding and dissecting the patient-physician relationship, and you've written about that. And you also told us that you thrive in the border between medicine and neurology, and then you present a case that has hypothyroidism and a stroke and talk about your fantastic relationship with the patient and his family. And so I hope you realize that we also have sneak ways to finding out what may be coming our way. But anyway, thank you so much, Avi. It was a real treat, and congratulations, Himun, on your very successful first scribing on RLR.
And if
But
I can just
last
make
but not
one
least,
last comment, Robbie,
oh,
I
of course, Prof. Reds.
Robbie, like when I look at you, you just like remind me of my cousin. And that's why I feel so comfortable joking around with you. You have such a charismatic, kind, gentle way about you. So thank you so much for brightening my day.
No, absolutely. It felt I was like low key nervous, like I'm doing this after so long. Like I think any of us should be to bring quality to something that is being presented to so many people who are taking out their time. Uh, but the fact that it feels so comfortable with everyone here, uh, the whole team is so amazing. I think that just gets the best out of us. I feel comfortable talking about things that I personally felt or I would want to share or learn. So I think that comfort that CP solvers brings to all of us, I think that's the reason that we feel so connected. Even if I'm sitting on my boards and there's a new video that's being released, I'm like, I'm gonna watch it right away. So thank you for doing a great job. I'll also share the link to my medically mediocre channel if you guys wanna like watch it and definitely give me your feedback. Um, uh, but hopefully this patient can find his way in one of my poems someday.
Amazing, Avi. Thank you so much. Yeah, well, I think, oh yeah, there you go. You just shared it in the chat. Wonderful. All right, Jimena, the mic is yours.
Ah,
Well, first of all, I want to start by thanking you guys because these types of cases not only are educational, but we could all see the passion for medicine that you all three shared. So that's very inspiring, especially for incoming interns. So I want to thank you for that. And for the teaching points, I like to group them. I think that we saw like three main topics here: the neural pearls, the endocrine pearls, and some other pearls that Dr. Avi shared with us. So for the neural pearls, remember that the neurodiagnosis is going to equal focality times the tempo. And it's very important to assess the delta, which means the change of the neurosymptoms that the patient had, and then that it's presenting as we're seeing him or her. Then we got to remember that thyroid problems can cause subacute conditions that can make that delta and that tempo a little bit confusing for us. But we can also rely on the things that we know, which one of the things that we knew about this case was the focality. So it can be due to hemorrhages, tumors, or seizures. So we should be encouraged to look for them as we study the patient. When we think about tempo too, the fact that we have an acute onset might be concerning for inflammatory conditions. So that should be also on our DDX. And when we have a unilateral neurological syndrome, we tend to relate it to recent events like falls in this case, but we also need to remember that can be coincidental, which would be very important to seek in the diagnosis of the patient. And then another great pearl was when they talk about the delayed seeking of care. Usually we attribute that to the barriers that the patient might have, but in this specific case, it might be an alarm for us to assess the sensorium and to also infer the severity of the neurological compromise that the patient is present. And then for the endocrine pearls, we also learned that the TSH levels mildly correlate with the severity of the clinical manifestations. So we shouldn't pay much attention to the specific number of the TSH. Also, TSH medication should be taken with an empty stomach or it can reduce the absorption. And that's a key and important point to teach our patients. I also personally learned that hypothyroidism can cause pericardial effusions. That was a very cool pearl for me. And then we should be observant of the clinical symptoms that are going to resolve after we have given the thyroid replacement therapy, as it can make a little bit more clear the picture of the syndrome that we're dealing with. Other pearl that Dr. Avi shared was that the presence of AFib in the context of stroke can change the management and the risk of getting more strokes of the patient. So that's why it's so important to actually assess if the patient has it or not. And lastly, I want to finish with, I think it's one of the most important pearls that we learned from this VMR, is that when we have patients with chronic conditions, they're totally allowed to be decompensated from those chronic conditions, and they're still going to be vulnerable to acute independent conditions. So that's something that we need to take into account, because most of the patients that we're going to see are going to have chronic conditions. So that's all I had for you guys, and it was a pleasure to do the teaching points for you.
Oh my gosh, that was so cool. I just absolutely love the like breakdown into specific parts and then big picture thematic takeaway. It was I don't think I've seen that you do that before. Is this the first time you've done that?
Well, I've tried. I think that as you do more teaching points, you kind of get a little bit more mature on the way that you do it. I think that that's how my brain works. Like I like to put things on buckets because it's easier to remember. But thanks for the feedback, Ravi.
Yeah, for sure. I've seen you do the buckets before, the buckets and then like a big picture thematic takeaway is so cool. Really awesome job, Jimena.
Thank you.
Robbie, thank you so much. That was very good teaching. David, are you in a place where you can unmute yourself? If you are, David, I wanted to ask you because I said the word Hashimoto encephalopathy, and apparently that's an obsolete term. So if you're in a place that you can unmute yourself and share with the audience, the viewers, because they're not going to see our chat, the right terminology that we use. If you're not, I did Google it, and it seems like it's steroid responsive encephalopathy. Is that it, Robbie? The
Oh,
so-called
I don't know. I had no
You
idea.
do know.
No,
I
I
don't
had no
know.
idea. My immediate response to that term, steroid responsive encephalopathy, was like I can think of maybe 100 things that are steroid responsive encephalopathy. So yes, no, I'm very ignorant, Prof. Rez.
So where are we with the status of this Hashimoto? Tiago said it doesn't exist. Is this an obsolete term, or where are we? What's the day? What's the moment that we need to know right now?
I think there's encephalopathy in the chat, Prof. Rez. Maybe you should throw in some steroids, see what happens. I didn't know that there was. I mean, I can see why there would be. I can see why there would be controversy because I remember when I read a case or something um, that many patients who have other encephalopathies for other reasons have a positive TPO antibody. So that the making that diagnosis is always tricky because if you have encephalopathy and a positive TPO, it could just be true and unrelated, you know? So I knew that there was controversy. I just didn't know that that resulted in renaming, but we're renaming everything, Prof. Red. Half of what I have to do is learn the new name of another condition these days. Anyway.
Oh,
Thank you.
also, Ravi and Reza, because we have you here, there was one point that I had thought about, and I would love to have your take on it because I think this is a great place for everyone who's here to also think about it in a way. So one thing that I see when a lot of times patients get transported from neuroservices to medicine services for like once their acute management of stroke has been done, we see a lot of times the confusion being of them being on DAPT for 21 days and sometimes being on 90 days. Oh, and then a lot of times the medicine interns are like, okay, whatever neuro has written, but we never delve into like, why is it 21 days sometimes and why is it 90 days sometimes? We just continue it for those times. And to my understanding, how I understood it, and I would love to share it with you and whatever your takes are to help me understand better and for everyone is when the initial stroke management is being happening, when we've ruled out it's no hemorrhage, it's an ischemic stroke, but we do not yet kind of know what might be the etiology for it. And if it fulfills certain criteria, like it's not too big of a stroke that could cause hemorrhagic transformation, we want to start them on a 21-day DAPT regimen because that helps by trials in decrease the risk of recurrent stroke much more successively. And at this time, we do not know what the etiology of the ischemic stroke is. We start them on 21-day DAP. However, sometimes what ends up happening is that you anyways get a CTA done and you do see a large vessel atherosclerosis or large vessel disease that might be the cause of the stroke, of the ischemic stroke. In those cases, the trial suggests like having someone on 90-day DAPT is definitely beneficial. So how I have started looking at it is not as 21-day versus 90-day DAPT, but 21-day DAPT that stayed 21-day DAPT because there was no large vessel atherosclerosis versus 21-day DAPT because they were put on it because it was an ischemic stroke that now became a 90-day DAPT recommendation because the cause is likely a large vessel disease. So I think that helped clear a lot of confusion in my head. But happy to have your thoughts if that's correct.
This 90 day is brand new for me. I thought it was just 21 days. So thank you for teaching me that, Avi. And I'm going to include a link, and I think you'll really appreciate this. This is from a neurologist. If you go to the bottom of my note page here, it's a YouTube video of a neurologist at UCSF who's like, Robbie will tell you, probably one of the best teachers at UCSF, and he's like a stroke specialist. Highly recommend you watch that, not because you need more knowledge, but just see how he teaches and but he talks a little bit about therapy. It's like really cool stuff. That he gives an update every year. Highly recommend that. But I don't know if Robbie has any comments on the duration of DAPT or not.
I was sitting here being like, oh, I vaguely have heard these things because, I not because of my internal medicine hat, but because in the ER we have to discharge a lot of these patients because they don't need to stay. And so I've been so confused about this point, and you finally clarified it for me. So I have nothing to offer but gratitude again. for for this clarification, which will probably come in handy within the next 2 weeks. So I appreciate it. That was a really, really simplified takeaway, which I'll recap. If you have a cardioembolic or any embolic stroke, a cardioembolic stroke, you get anticoagulation. If you have a stroke that is coming from an embolism from atherosclerosis from the often ipsilateral carotid, you get 90 days of DAPT. If you have a stroke from another mechanism, then you get 21 days, which is a really, really nice simplification. Thank you, Avi.
And
You got to come back for more.
And that might be an oversimplification. Like there are definitely certain criteria, but I
Yeah,
think that,
for sure.
that definitely helped my head like think about things in buckets. Yeah.
Remember, Avi, your YouTube channel is mediocre medicine, but that's all we offer here all the time. It's just mediocre medicine. So the simple is the way to go. All right, y'all. Have a great rest of your day.
Thank you so much, guys.
Thank you.
Thank you, Avi.